and this experience have been tackled through the Egyptian National Viral Hepatitis Program since 2006. So my presentation will briefly discuss the history of HCV disease in Egypt, the control program of Egypt over HCV, the impact of cure, and can we eradicate HCV in Egypt, and what had to be done in order to reach this level. So as we all know that HCV is a progressive disease with serious sequelae, where in those who get the acute infection, only 15 to 25% will clear the infection, while 75 to 85% will progress into a chronic stage, and in 10 to 20% of these will reach the cirrhotic stage within 20 years. And of these, 1 to 4% will develop a hepatocellular carcinoma, and 50% will develop decompensated cirrhosis with a 5-year survival rate of 50%. So this is really a serious disease and has its own implications. Regarding the HCV prevalence in Egypt, Egypt is the most affected nation by hepatitis C virus. Systematic reviews, meta-analysis, and meta-regression were conducted to estimate disease burden in Egypt. Incidence and prevalence were high across all populations, with a prevalence of genotype 4 in 94% of the infected persons. So the prevalence was, the pooled mean HCV prevalence was estimated at 11.9% of the population, which is quite high. 55% among populations at high risk, 14% among populations at intermediate risk, and 56% among populations with liver-related conditions, and 35% among special clinical populations like those who receive repeated blood transfusion like thalassemia, chronic renal dialysis, hemophilia, and other disorders. So it was really a challenging situation in Egypt. The mean HCV viremia rate was estimated at about 66%. HCV prevalence is high, with evidence for ongoing transmission, mainly through healthcare. 2/3 of antibody-positive Egyptians are chronically infected and need treatment. Clinical populations should have priority for screening, and despite the large-scale epidemic, prevalence appears to be declining. This was the situation that we started to see since 2015 and onwards. So there was a model in 2016 about the disease burden, which said that about 5.2 million hepatitis patients, people have chronic hepatitis. Those who received at this time in 2016 antiviral therapy were only 365,000. Compensated cirrhosis was estimated to be 630,000, decompensated about 138,000, and hepatocellular carcinoma about 16,000, totaling about 6 million people affected with the disease. And the annual newly diagnosed cases was estimated to be about 110,000. 110,000 newly infected persons each year, according to this modeling. And this had its economic burden. So it was estimated that the Egypt direct healthcare cost due to the HCV infection is about $670 million, and that the indirect economic impact is about 3.7 billion. And this is close to 1.8% of the Egypt Growth Development Product, GDP, which is similar to the cost of diabetes mellitus and cardiovascular disease cost in the US. The intangible costs to society and families were not assessed in this model. So based on this, it was discussed that treatment of large numbers of patients with effective therapy is the best option to control this epidemic, where curing a patient saves about $10,000 for next 15 years, totaling per patient like $150,000 cost saving, and about preventing a case saves about 20,000 for the next 40 years. And without active prevention, there will be 1 million more cases in 2030. So it was very clear that mass treatment is very important to step to eradicate the disease. So the Egyptian government tackled the HCV problem because until 2006, Egypt did not have a comprehensive national program for control of HCV. There was no large nationwide survey for the disease. Accurate prevalence data are unavailable. Government did not cover HCV therapy, no national guidelines for treatment, and limited infection control program. And due to this bad situation, the Egyptian government established the National Viral Hepatitis Committee in 2006. The objectives of this committee was to track prevalence and incidence of hepatitis B and hepatitis C in the population, to implement infection controls through awareness, injection safety, vaccination, blood transfusion safety, and screening for new infections, expand across access to treatment under subsidized schemes, meaning that the government should cover partially or totally the cost of the treatment, maintain high quality scientific research, and implement effective monitoring to ensure accountability and optimum use of funds, because it was obvious that the Egyptian government has to dedicate significant funds to control this problem. And in 2014, the committee established the Plan of Action for the Prevention, Care, and Treatment of Viral Hepatitis, a plan that was for 4 years between 2014 and 2018. And for this, the government established about 51 treatment centers for hepatitis C distributed across the busy Nile Valley, busy populated Nile Valley, because as you all understand that the Egyptian population is totally concentrated around the Nile in an area that's only about 15% of the whole area of Egypt. So the objectives of one of the primary objectives was the National Hepatitis C Screening Program through HCV test. And here we looked into 2 categories: to screen, to diagnose patient, or to screen blood donors to ensure safety of the blood. Screening patients was mainly to diagnose active infectious cases. So the algorithm of testing for hepatitis C for the patient was doing mass HCV antibody screening, and those who proved to be positive, they were referred to do the nucleic acid test to see if these patients have active viremia or not. For the blood donors, we had several options of blood screening. The mandatory screening is through HCV antibody screening. But in the meantime, there were other options, the antigen assay or antigen antibody assay, and the nucleic acid testing. And I will discuss this in a later stage of this presentation. So the screening algorithm for screening the population was based on the CDC algorithm, where HCV antibody test was done. If non-reactive, there is no HCV antibody detected, so we stop at this point. If it is reactive, we perform HCV RNA by, if not detected, no current HCV infection, and we need additional testing as appropriate according to the clinical evaluation of the patient and if he is showing any active signs of active hepatitis. If the RNA is detected, then the patient has a current HCV infection and he will be linked to care to do the proper investigation and start the antiviral therapy. For the mass population screening, 27 centers for HCV screening were initiated and equipped in addition to existing centers. HCV screening for 45 million persons over the next 5 years. But actually what happened is that the government started a very aggressive screening program in the early 2018. And based on this, the government could achieve a screening of 65 million of the population during the year of 2018. And there was a huge database established for those people who were screened for HCV, not only HCV, they were also monitored for hypertension, diabetes, obesity. And this created a very important health database for the infectious and non-communicable common diseases in Egypt. Those who proved HCV serology positive patients were confirmed by HCV quantitative PCR. And if they had the viremia, they were referred to treatment centers. At the end of the based on this, they will start receiving the new direct antiviral agents. And at the end of the, after finishing the direct antiviral agent courses, they had another PCR test to confirm that the initial viral eradication. And then it was to be followed sequentially if there will be a recurrence of infection or rebound of infection or not. Regarding the blood safety, I mean, I would like first to discuss with you the kinetics of any viral infection so that we can understand the rationale behind the different viral screening technologies that are available now for blood screening in order to ensure that the blood is safe. So for any viral infection to happen, the virus, after entering into the bloodstream, especially the blood-borne viruses, will target the specific organ. And in our case, in hepatitis C, it is the liver, where it will disappear from the blood and start multiplication inside the liver. And in this period where the virus entered into the bloodstream, targeted the target organ, which is the liver in our case, and disappear from the blood is called the eclipse period, because at this period, there is no viremia in the blood, although the virus is active in the liver. And then due to the viral multiplication, the virus starts to be shed into the bloodstream in the beginning at a very low concentration, but gradually it increases and it differs from one virus to the other according to the rate of multiplication inside the infected organ. And at this time, at the very low viral loads, the nucleic acid testing may not detect the very low viremia, a phase that we call pre-NAT window period. And then as the viral load starts to increase gradually, we start to see the NAT. And then in the case of HCV, the antigen detection starts later on. And then after a period of time when the body responds, the antibody starts to appear. And when the antibody starts to appear, we have one of two scenarios. Either this antibody is able to clear the virus from the body spontaneously, and kind of antibody that we call neutralizing antibody. So it will eradicate the virus and the NAT starts to become negative, although the antibody is positive. or it is a type of antibody that's not able to eradicate the virus. So the virus is still in the blood and the antibody is positive, a case that we call chronic infection. So another important point as an implication of the different stages of the viral infection is what we call the threshold of infectivity. And the threshold of infectivity means how many virions will be in a blood unit that can produce infection in a recipient. And this also differs according to the stage of the viral infection in the body. So if it is in the acute phase before the development of the immune response of the body, the infectivity threshold will be only 3 to 10 virions in a blood unit, in a whole blood unit, not 3 to 10 virions per ml, but 3 to 10, so a minimum existence. And that's what is really also serious, that it is in the pre-NAT window period that it can cause infection. And of course, it will cause infection in the serological window period when the virus is existing and the antibody is still negative if we are testing our blood with only the antibody assay. Then in the chronic stage where we have the antigen and the virus and the antibody coexisting together, the infectivity drops by 100 times, because at this time the virus is complexed with the antibodies, a stage which reduces the viral infectivity to 100-fold less infectivity compared to the primary stage where it is only during the acute infection period. Another point to understand the relevance of each of the tests is what is called a Poisson distribution. And this refers to situations where the viral load in the blood is extremely low. So the viral particles will not be existing evenly. If I imagine that the sample that will be withdrawn by the probe of the analyzer is this one. So the viral particles may not exist in all the parts of the sample. And based on this, if I do the test in single test, it may happen in an area which is lacking the viral particle, and based on this, the NAT or the nucleic acid amplification will not happen and it will test negative. But if we repeat several times the test in this sample, after certain number of repetitions, we will find discordant results between positive and negative. And this typically happens in the very early stage of the window period, the area which we call pre-NAT window period, or with the occult infection where the antibody is clearing to, the virus to a minimum, but is not completely clearing the virus from the blood. So based on this, for hepatitis C, we have several markers to test to make sure if the blood is infectious or not. And these are the HCV RNA or HCV NAT screening. And as I said, even with the ID NAT, there is a window period of 2 to 3 days before the viral load becomes to a level that can be detected by the NAT screening assays. Then we have the antigen assay, which comes in a later stage and which reduces the serological window period by a significant number of days. And then we have the anti-HCV, which happens typically after an average of 70 days. So if we are testing our blood with only anti-HCV, you can expect that we have a window period of about 70 days in an early newly infected person. And then we have a stage, if the anti-HCV could clear the infection, which happens in 25% of cases, we'll find that the anti-HCV is positive while the NAT is negative. So these are the different scenarios. And in order to study the efficiency of the different screening scenarios, we studied this in a study that was done between 2007 and 2015 in Egypt, where we compared the relative or the residual risk of infectivity in a blood unit, especially the packed RBCs, if we only do the antibody assay, or we do the chemiluminescence antigen assay or combo antigen antibody assay. If we do the NAT testing in a mini pool, meaning we pool the several samples from several blood units and do the NAT assay for this pooled pool in one test, or if we do screen the blood by individual donation NAT assay. So as I said, it was to estimate the residual risk if we only do anti-HCV assay, if we only do HCV CLIA antigen or combo antigen antibody assay, or if we only do NAT assay, ID NAT assay. I will skip these points in order for the time, but what happened is that we screened by HCV antibody assay about 15,000 first-time donors, and in the meantime ran the HCV RNA ID NAT concordantly with the HCV antibody assay. And the results that we found, about 700 blood donors positive for HCV. The distribution between the HCV NAT and serology was like this. 5 cases at a rate of 0.7% were ID NAT serology negative, which is called serological window period. 444 had concordant HCV RNA positive, anti-HCV positive, and about 252, about 35% were only anti-HCV positive, NAT negative. So in order to analyze the possibility of infectivity of the different units in the different scenarios, we started to quantify the viral load in each of the scenarios. So the 5 HCV RNA units, we did the HCV RNA, quantitative HCV RNA in AmpliCore monitor. And then we had a subset of 50 samples from the concordant results of the blood units that had both HCV RNA and HCV antibody positive, and a subset of 175 units tested in 10 replicates of the NAT assay for those who were positive for anti-HCV but negative for NAT. And so the results were like this. In all the 5 units of the NAT window period, they had a viral load between 100 to 10 times 10 to the 7 or more, which means that they are really infectious units. For those who have that have both the HCV antibody and HCV RNA positive, they had a high viral load as well. So they are still infectious. Then we looked into among the 175 subset of those who were HCV serology positive but NAT negative, testing them in 10 times repetition. And we only found only 2 units out of these 175 units with a very, very low viral load of 0.5 and 1.4 copies per HCV viral copies per ml. So what are the implications of this? When we look to the viral loads in the 5 HCV window periods, all had a very low viral load except one that had a level below 100 copies, which was about 82 copies. And for this, when we tested it if we do it in dilution, meaning in pool testing, then the capability of the NAT assay in pools will increase the residual risk of infectivity progressively. So if we pool 2 units, I mean, if we test in IDNet, it's 100% detection. If we do pool of 4, it becomes 92%, and so if we do and so on. If we do a pool of 1 in 64, it becomes 4% that we will detect such a unit, which will pose an increased residual risk. So the IDNet showed that it is the ideal situation. Also, we compared the analytical sensitivity of the NAT against the HCV chemiluminescent antigen assay and HCV antigen antibody combo assays. And the sensitivity of the NAT was on average 1,780 folds higher than combination assays and HCV antigen CLIA respectively. So this means that there is the combo assays or the antigen assay can reduce the infectivity or the residual risk, not in a significant way, but still it is an improved safety tool. So if in a country that cannot afford NAT screening, IDNet screening, they can still use the combination assays, and this will reduce the residual risk by 38 to 47%. So overall, we found that the probability of infection, if we are doing the HCV NAT screening, it is 1.5 or in 600,000. If we do the HCV antigen antibody assay, it is 1 in 11,000. And if we are doing the HCV serology screening, we may have an infection every 7,500 units. So this shows that different. Of course, if we do the combination of HCV serology and NAT screening, this will increase the safety very much. So this is about the different screening scenarios and how can we decide on the best options according to what is available in a country and the prevalence of the viral infection, and which should be assessed in each country according to the prevalence, the incidence rates, and so on. But coming back to the HCV program, in the last decade or the second decade of the second millennium, there was the introduction of the new direct antiviral agents against HCV, and it was really good to see that these drugs can cure the disease, and this is the only viral infection that can be cured by treatment, because other viral infections like hepatitis B and HIV, the medications can only suppress the replication of the virus but cannot eradicate the virus, while in this new scenario, the HCV can be cured by the new direct antiviral agents, a situation or a case that we call it sustained or viral response, which will lead to a significant reduction in morbidity and mortality. So based on this, after this huge screening program, the government of Egypt embarked on mass treatment of those who were diagnosed to have HCV infection in starting from 2017-2018. The treatment of the costs was paid by the government directly in 83% of the cases. Healthcare insurance covered 9%, and private sector or out of the pocket was 8%. And based on this, the government could negotiate the price of the new direct antiviral agents. And you can see that the cheapest was close to $6,000–7,000 for a course in Brazil, but Egypt could reach only to $800, and with the production, it was even cheaper. And this was based on the agreement with the manufacturer because of the ethical approach of the government of Egypt to treat all the population at its cost. So with this, we could, I would say that we are now in a stage that we almost eliminated the disease after the massive treatment program since 2017 up to 2020. I would say more than 5 million patients received treatment, and that the cure rate was ranging between 70 to over 90% according to the different protocols of the treatment. So with this, we would say, I mean, we were planning in the viral hepatitis committee to reach the eradication stage and reduce the new cases into a minimum by 2030. But due to the seriousness of the Egyptian government and the importance of eradicating the disease, I think that the mission has been achieved between 2014 and 2020, reducing 10 years time. So what is next? Now we have a peculiar situation in Egypt. The burden of the disease was estimated at 5 million, which means that these 5 million, majority of them have HCV antibody test positive. Now we have two categories of people with HCV positive serology negative net. Those who spontaneously cured the disease, which we saw that they were about 30% of the infected population, according to our blood screening program, and about those who were treated and cured from the infection. So those people now start to ask us if they can come back to the donor pool and if they can donate blood. So with this, we need to address certain questions or to modify our blood donor deferral. Should we consider to replace anti-HCV serological screening by NAT in Egypt, as well as similar countries with high prevalence of HCV infections? Should we maintain HCV serology screening in addition to NAT in these areas, but accept blood donors who are serology positive and NAT negative? When can we bring back cured HCV patients to blood donor pool? What questions should we include in blood donor questionnaires in regards of cured HCV patients? How to define NAT blood screening algorithm for donors who reported that they are cured from HCV infection? The ethical consideration of cured HCV patients who would like to become blood donors, and what is the cost effectiveness if we need to study this population and if we find them safe to bring them back to the blood donor pool. So based on this, we propose a study to answer the questions, and the aim of the study, this study will be shared between Egypt, South Africa, and USA, and each country has its aim of a different aim. So in Egypt, revisit donor deferral criteria of serology positive NAT negative blood donors. South Africa is to stop HCV serology testing and depend only on ID-NAT. USA to study feasibility of HCV ID-NAT screening to replace HCV serology. The inclusion criteria are individuals with HCV serology reactive, NAT non-reactive. Samples are collected after 1 year from diagnosis of HCV convalescent or cure of participating individuals. Number of studied population equal numbers from HCV convalescents and the cured individuals, a number of included individuals from both categories to be determined. As I said, the participating countries are Egypt, South Africa, USA. This is the algorithm of the study. And at the end, I would like to thank very much for SNIPE. We have started to use in our blood center, the Maglumin 2000, since about a year. It's working very well. We evaluated it against our external quality assurance samples coming from the UK NIQUAS, and it was 100% successful in responding to these external quality assurance samples. So at the end, I would like to thank you very much for your patience in my presentation, and thank SNIPE for organizing this important webinar. Now it is my pleasure to introduce the second presentation, which is about inflammation biomarkers in progression and prognosis of COVID-19. It will be presented by Dr. Walid Tamimi. And Dr. Tamimi is the head of clinical chemistry at King Abdulaziz Medical City National Guard. He is an associate professor at College of Medicine, King Saudi bin Abdulaziz University for Health Sciences, consultant biochemist at Saudi Commission for Health Specialists, and president of Saudi Society for Clinical Chemistry 2014 to 2017, general manager and consultant Smart Lab Riyadh, Saudi Arabia, and consultant to Saudi MOH. I will stop sharing, and I will ask Dr. Tamimi to kindly share his presentation and stuff. Please, Dr. Tamimi.
Assalamu alaikum.
Alaikum assalam.
Is my presentation shared already? Or?
Yeah, it is shared now. But if you can maximize it, Dr. Tamimi, yes.
Okay. Bismillah ar-Rahman ar-Rahim. Can everybody hear me well?
I can hear you.
Okay. I hope all participants are hearing me. My name is Walid Tamimi. Thank you, Dr. Majdi, for nice introduction, and thank you for the company SNIPE for organizing this webinar, sharing some information with my colleagues in Egypt about implementation of inflammatory marker in my lab in Saudi Arabia. We'd like first to disclose that the mentioned specific companies or of certain manufactured product does not imply that they are endorsed or recommended by the Saudi Society of Clinical Chemistry in preference to other of similar nature that not mentioned. And this slide, I just want to show you that the medical city, King Abdulaziz Medical City, where we have the old hospital here, and the new laboratory, we see it in the medical city, and the new children's hospital at the back, and the university on the left side of this slide. And then we have a huge emergency department in this area. We have 60 beds in this emergency department, and surgical tower here, where we have the service to National Guard and their dependent, and some also public population. This is another view, show the university from different side, and show the lab at the right up corner of the slide. It's a huge laboratory. This is the laboratory. We have 16,000 meters square. We have all service. We have moved to this lab during 2015. Also in my lab, we have total laboratory automation. We do the clinical chemistry, hematology, and serology marker including some storage and allocating pre-analytical and post-analytical step as all total lab automation. We received about 10,000 samples per day, including all disciplines. But again, the lab is under pressure of increasing the workload, and always our colleagues in the medical setting, they request us to do more testing, including this new inflammatory marker that has been raised during the coronavirus epidemic. And for this, we have started to implement IL-6 and procalcitonin, including to what we have. In this slide, as we always basically describe the virus, the information, the basic information of the virus, where it has different sites where we can target the gene, which is this RNA virus, and has the difference gene where the technology can work and detect the virus using the PCR technology. And this also magnifying part of the spike. We can see that it has two parts to receive at the every cell and epithelial layer, where it has angiotensin converting enzymes to receptor and receptor of binding domain, as we're going to see in this slide, where the epithelial cell receive the virus in two receptors here, including the ACE, angiotensin converting enzyme 2, and temperase SS2, where these two can receive the virus and embed it inside the cell, where the virus has two processes. One is apoptosis, where it can be enter into the endothelial layer, or it being also maturate and be away or out of the epithelial cell in the airway, where it can infect other person when the person contact to other. As we can see here also on the right side of this slide, the site where the angiotensin converting enzyme 2 is found in most of the respiratory system, where it is the receptor site for the coronavirus. So also we will not go in the clinical characteristic of COVID-19, which is the symptoms, most commonly the fever and cough and symptom production and fatigue, including other symptoms. But the diagnosis is based on the two scenarios: suspected and then confirmed. The suspected is epidemiological history, clinical features, and using the other imaging, CT scan, or bilateral involvement of chest radiograph. But the most important is to confirm the cases, as all of us know, is the reverse transcription real-time fluorescent PCR assay. Some other can do virus genome sequence, which is also a very confirming way, and then using serological IgG and IgM antibody according to the some organization body, including the Chinese guideline. But the complication, as mostly is from the top to the lower, is the sepsis and respiratory failure and acute respiratory distress syndrome. And then the secondary complication or comorbidity is when the patient have heart failure or septic shock and coagulopathy, acute cardiac injury. In the clinical application of serological indicator or in COVID-19, On admission, the physician tried to diagnose and then monitor the patient. For the golden standard, as we said from the previous slide, is the PCR or RT-PCR or sequence. The aid method is antibody testing, but we have to include some also routine assay like CBC or D-dimer, serum biochemical test for kidney and liver function, and so on. But most importantly, also the inflammatory marker, including D-dimer, that we have to establish the baseline when we start to monitor or to observe the prognosis or regression of the patient. But important that we should bear in mind that the procalcitonin is very important in sepsis. Interleukin-6 or IL-6 is sepsis and septic shock, and C-reactive protein septic shock as well can be used, and D-dimer in abnormal coagulation. These first four can be used, as I said in the previous slide, in the most primary comorbidity, the sepsis and respiratory failure and acute respiratory distress. And the second group in a black color in the secondary complication for heart failure or liver or kidney infection. So in this slide, based on the COVID-19 that will hyperactivate inflammation and coagulation system, we have these two, the inflammation response and the coagulation response are initiated when the virus enters to the respiratory system, and we will see on admission that increasing of this inflammatory marker, IL-6 and C-reactive protein and D-dimer and procalcitonin. In the severe cases of COVID-19, the interleukin-6 will remain very high. C-reactive protein greater than 10 will remain at 81.5% of the patient. D-dimer will be above 0.5 in 59 or above patient infected population, and procalcitonin will still remain low unless the patient has sepsis or develops sepsis in about 86% of the population. When we compare the survival outcome with non-survival outcome, we found that in those has been survival, interleukin is average 6.3 compared to those non-survival with 11.6, and C-reactive protein is greater than 10 in about 58 or above % of survival population. However, it is still remain in the non-survival, it's remain high, but in about less than 91.1%. D-dimer 0.6 in survival, but the average is very high in non-survival, 5.2, and procalcitonin is less than 0.1, but higher than in about 0.5, greater than 0.5 in non-survival population. So the key biomarker to evaluate the inflammatory reaction, researchers show the abnormality of laboratory of inflammation indicator among COVID-19 patients, such as C-reactive protein, procalcitonin, and interleukin-6. Moreover, the procalcitonin shows a significant differences in the survival and non-survival that may be due to the secondary infection and severe complication to cause procalcitonin increasing. These studies are supporting the algorithm that I have shown in the previous slide, and show that most of these inflammatory marker or other marker can increase or decrease in the severity or the presence of complication. Another study showing that D-dimer, I'm going to break down the range and showing the for survivor and non-survivor, with including serum ferritin and procalcitonin and interleukin-6. And that also in another study showed that in survivor, the drop of D-dimer, drop of high sensitivity cardiac troponin, especially in those comorbidity of cardiac cardiomyopathy. Interleukin-6 also drop in survival population, and including serum ferritin as well. So because we in clinical chemistry lab, we do the inflammatory marker. We used to do C-reactive protein a few years ago, and that was no problem in offering this test to clinician. It is a protein found in the blood and raises in response to inflammation, produces in the liver an increase in following interleukin-6 secretion by macrophages and T cells. Its physiology role is to bind the surface of dead cells and bacteria to activate the complement system. Normal concentration is between 5 and 10, but increasing with aging as well. In severe bacterial infection and burn, it's increased to up to greater than 200 microgram per liter. ESR worked in parallel with C-reactive protein, but sometimes it be normal while C-reactive protein is elevated and returned to normal more quickly than ESR in response to therapy. In correlation study that we did in our laboratory comparing one of the nephelometer analyzer versus SNIDE Maglobi 800 in National Guard Hospital, we found a very good correlation between the two analyzers using different technology, using chemoluminescence in the SNIDE and using nephelometry technique or scattering of light in the nephelometer. This table shows the comparison between the two analyzers, the nephelometer and the Maglobi, and showing the different characteristic of each method to be compared, and each method has its own advantages. The procalcitonin is a peptide precursor of hormone calcitonin, which is calcitonin is involved in calcium homeostasis and produced from free procalcitonin, which is cleaved by endopeptidase. Procalcitonin also produced in neuroendocrine cells of the lung and intestine, and this raised procalcitonin level during the inflammation is associated with bacterial endotoxin and inflammatory cytokine. In this study show how important that the progression of level of sepsis and procalcitonin, and categorize the different stage in sepsis and septic shock compared with other marker that show that procalcitonin is the best marker for sepsis compared to other marker with a high area under care compared to other marker with a high sensitivity and specificity. Also, we have compared the SNIDE Maglobi with one of the Graham chemoluminescent analyzer, and again showing very excellent correlation between the two analyzers. Even though the two analyzers using the chemoluminescence technique, however, some advantages of using it using the Maglobi 800. Interleukin-6, which is the new test being offered in our lab a few months ago to support the clinician to monitor and the prognosis of patient of COVID-19. Interleukin-6 is a cytokine, stimulate the proliferation and differentiation of immune cells and produced by fibroblasts, monocyte, and macrophage, and so on of these cells, induced in acute inflammatory reaction associated with injury, trauma, stress, infection, brain death, neoplasia, and other situations. Reach peak concentration in bacteremic patients several hours before the rise in C-reactive protein and procalcitonin concentration happen or occur. As I said, it's used to assist in identifying severe inflammatory response in patients with COVID to determine the risk of intubation with mechanical ventilation. So the physicians are having the result to help whether we can go with the mechanical ventilation to COVID-19 patient or not. Again, also we compare this with different technology with the SNIPE Maglumi 800 and showing very excellent correlation between the two analyzers. And these analyzers are using sandwich electrochemiluminescence immunoassay compared to chemiluminescent immunoassay and showing very good advantage in both. D-dimer also have been compared and showing using one of the coagulation analyzer compared to Maglumi 800. This is one of the advantages of Maglumi 800 that offer D-dimer. So you can have the 4, including ferritin, which I have not included in this presentation. So you can have 5 parameters of having on one analyzer to offer it to the inflammatory or inflammation conditions of the patient, showing very good correlation between the 2 analyzers. And again, we compare it with from the linearity and the labels and reaction times of each assay and normal range as well. So in conclusion, for routine tests on admission for inflammatory marker, we will expect that C-reactive protein, interleukin-6, and D-dimer will increase. Procalcitonin do not increase, but it helps clinician to distinguish bacterial infection from suspected patient. It assists the cause of COVID-19 patient by that indicating that C-reactive protein and interleukin-6 and D-dimer will keep increasing. Procalcitonin will increase, will remind the clinician if there is any complication caused by bacterial infection. And if in high mortality risk, the interleukin-6 will dramatically increase, showing significant variation between survivor and not survivor patient. And D-dimer also dramatically increase and showing the significant variation between survivors and non-survivor. Procalcitonin dramatically increase, remind clinician that the secondary bacterial infection has threatened the COVID-19 patient life. At the end, we have some questions that commonly been raised during some of the other webinar. Why does not show an exact value reflect interleukin levels in COVID patient on admission and during the period? The reason is different testing system offer a different reference cutoff value, which blocks the unify of the reference value of mild or severe COVID-19 patient. And meta-analysis that we can show here is that show that different clinical research offer various reference value, and the variation between the 2 studies are 6 times even. Some author offer a reference cutoff value of 55, but is not yet globally accepted. In another question, why D-dimer is a very important assay in COVID-19? And the answer is because it is powerful lab indicator to predict COVID-19 mortality, and also it is common laboratory abnormality in COVID-19. The third question that normally comes as a common question in the previous webinar is it enough of testing D-dimer assay only in COVID-19 for prognosis of coagulation? And the answer is testing D-dimer only is limited to comprehensively evaluate the situation of COVID-19 patient, but it is an economically an effective method since the general prognostic value of D-dimer. The summary finding of the D-dimer can also be found. I'm not going to read this to you, but showing some references that we use in collecting some information. And thank you very much for your attending and for your attention.
Thank you very much, Dr. Tamimi, for this very impressive presentation. If I can't, yeah, very good. So now we will, just a minute. So now we have the question and answer session. I have probably three linked questions from Ms. Emma Dai. The questions are, as we can see from the presentation, this is a question to Dr. Tamimi. The inflammatory indicators of IL-6, CRP, and PCT are related to the prognosis of COVID-19. So could you please introduce that the serum profile of these assays in mild and severe patients in Saudi Arabia? Could you please share your experience of reading the critical values of inflammatory assay in severe COVID-19? And whether the inflammation reaction is happening in a special organ or is a systemic response of our bodies. So Dr. Tamimi, if you can answer the questions of
for the first questions, I can just read back the question, whether the inflammation reaction is happened in a special organization or is a systematic response of our body. Of course, in some study that come to my knowledge, that it is happening in some special organizations, especially in the respiratory system. But this is also respond to systematic response of our body to the invasion of the virus as well. The immunity system will work according to the slide that I show, that inflammation and coagulation involving in this process or this reaction. For the second question, the experience of reading of the critical value of inflammatory assay in severe COVID-19. As we said, the most of that what we use is the convention cutoff value or critical value that we use. Of course, we are still collecting data to establish our own critical value of inflammatory assay, especially in COVID-19. We are following the international critical value cutoff to report to our clinician, especially in any case of severe COVID-19. For the third as we can see from the presentation, the inflammatory indicators of IL-6 C-reactive protein procalcitonin are related to the prognosis of COVID. So could you please introduce the serum profile of this assay in mild and severe COVID patients in Saudi Arabia? We have introduced this profile in mild and severe COVID-19 patients, especially in the organization I'm working. And I'm not sure if I answered the question correctly or with a good information to the to Emma Dial.
I think, yeah, thank you. I think it was clear. I have personally one or two questions to you, Dr. Tamimi. So, I mean, the definition of recovery from COVID-19 is clearly clinical if the symptoms subside for a period of time. I think it was estimated like 10 days to 2 weeks. Irrespective of the result of the PCR, we would think that this person has been or has recovered and will be discharged. But I mean, with the inflammatory and coagulation laboratory markers, there is no clear definition on when this person is really cured, and the patients keep testing themselves after discharge, and they still may have some of these markers high, and they are worried, and particularly in regards to using the anticoagulant while the D-dimer is still slightly high. So in your experience, how do you define this period, and for how long should these patients be kept on the anticoagulant?
Excellent question. Thank you, Professor Majdi, for this good question. We have, as we trying to aid the clinician, is to the prognosis of the patient who are hospitalized in our hospital to evaluate whether they can either go to different scenarios, especially if the patient has gone on severe situation and need more treatment attention or management, but also for the dropping of these inflammatory markers. There is no yet agreement when this marker will be resolved out of the body, even if the patient has been discharged. But once it's been coming to drop, this is good prognostic signs for the clinician to help them at least to go to the avenue of discharging the patient, especially when the virus has been cleared and the symptoms have been resolved from the patient.
Yeah, thank you very much.
I have an experience. I have
please,
one question for Professor Majdi regarding the HCV.
Yes, please.
I'm also following the HCV treatment, and we were really very, very happy that this medication has came in the last few years to help our population to resolve from HCV infection. But my question is, any recurrence of HCV has been occurred after using this medication or treatment?
Yes, I did not show some of the data from the local experience, but I mean, the recurrence was occurring according to the protocol of the treatment, whether it is a single or a combination therapy, in a rate between 7 to 20%. And there was also some reported cases of hepatocellular carcinoma after recovery. But generally, the results were excellent. I mean, compared to the mass, it's really an excellent therapy. Of course, also it depends if you are starting with one therapy and I mean, with the monotherapy. In a recurrent patient, you may try the combination therapy, which can, eradicate the virus.
Excellent.
Yeah. So I have also a question to you, Dr. Tamimi, since I have not received any more questions from the audience. And I don't know if it is in your scope. It's the NAT and serological testing results of COVID-19. I mean, in the diagnostic criteria, and even sometimes if you have the clinical picture, I mean, the symptoms and the CT chest and the inflammatory markers, and sometimes if you miss the early period of the PCR to detect sometimes patients come late. They do not come for medical care in an early stage because they think it's flu or something like this. And by this time, probably they come with a negative PCR, but with the full blown picture. But what we saw in sometimes is that discrepancies. I mean, sometimes we have the PCR as positive and no serological antibody response after a period of 10 to 15 days. And in the meantime, sometimes we have the full blown picture with a negative PCR and serological positive result. The other thing is the follow-up on the serological results. We saw in some of the patients that they tested at a period of time of the active infection positive, but soon after recovery, their serological test started, give negative results. And some who had high titer antibodies, gradually they have declining levels of antibody. So do you have any comment on these observations that?
Thank you again, Professor Majdi. This is one of the public important questions that they normally ask about the antibodies after they have been recovered from the COVID-19, especially when they tested positive.
Yeah.
What I am discussing with most of the infectious disease clinician is it depends on the severity of the of symptoms. First of all, we should understand that the immune system will only respond by producing antibodies is when it is symptoms are appeared, and especially when it is aggressive. The body will start to produce antibodies, IgM and IgG later on. And then when the patient is recovered, the PCR will become negative. Antibodies after 21 days or higher will appear in the blood, especially IgG. For the cases that they infected with COVID-19 and get positive but no symptoms, it is very controversial, and we don't see the antibody produced after a while time, and the patient is suspecting why this is not happening to me. We try to explain that this could be the reason. The immune system has not responded because no symptoms happen to, or no aggressive symptoms occurred during the infection period of time. However, we think that also collecting more information about the antibodies still ongoing, and we want to understand the response of the immune system especially in cases of positive PCR cases, but not producing the antibodies. On the other hand, we have seen the reverse, that some even I have seen 2 or 3 cases that who has been infected with the COVID-19 and PCR was positive, and they had aggressive symptom, but antibodies has not been detected in the blood or in the serum. Whether the technique or whether the body has not yet produced them still need to be clarified in the future with more studies.
Yeah, and you raised an important question also. I mean, 2 things. One is the discrepancy in the results between different assays. So in some assays, we are conducting a study on the production of the immunoglobulins against COVID-19 in small pools of convalescent plasma. And actually, yes, we did see that in some of the assays, it gives, I mean, very low titer of the antibodies. And in other assays, the same samples give much higher titer of antibodies. So there is really a significant discrepancy. And even when we compare the pool or the immunoglobulin results, because we are conducting also in these produced immunoglobulins, the titer of the neutralizing antibodies, the antibodies that can really eradicate the virus. And we found that sometimes it's also discrepant with the routine antibody assays. So in some, it showed very low titer in the total antibody assay, while the neutralizing antibodies were higher, which is not logic. And in some, we have very high total antibody and low neutralizing antibody levels. But I mean, and also from the lab that does the individual units, plasma units, neutralizing antibody assay, they reported to us orally that they find the neutralizing antibodies in a maximum of 30 to 40% of those who had the infection. So not all the individuals have the neutralizing antibodies. So I mean, but regarding the discrepancy in the results for the total antibodies, do you see it between different techniques?
Yes, I have seen that. Currently, even I am working to evaluate one of the point of care analyzers that use capillary blood and there is some discrepancies between the titer of antibodies between the 2 analyzers.
Yeah.
Yes, we do. Yes. We do want.
Yeah. So I'm not sure. I do not see any questions from the audience.
No, I haven't seen.
Do you have?
No.
Do you have any?
I think we have answered maybe some of them. No?
Yeah, I think we answered most of the questions. So if there are no more questions, I would like to thank Dr. Tamimi very much for his presentation. It really contained a lot of important information in this time where we are still learning about this pandemic. And each day there is new knowledge. So there is nothing concrete about this. We are still, even as medical professionals, learning every day of what's new in this disease. And we hope that in a very soon time that we will be able to control this pandemic, which has, had a very detrimental global effects, not only from the health point of view, but also from the economic point of view and from the social and psychological point of view. Thank you very much, Dr. Tamimi. It was really a very important presentation and very important knowledge about this disaster. In the meantime, I would like to thank very much SNIPE for organizing this webinar and supporting it to share important data about infectious diseases, whether the hepatitis C or the COVID-19. Many thanks to the audience and I hope that they have gained some relevant information to what they expected from this webinar. And with this, I would like to thank all and close this meeting, the webinar. Thank you very much.
Thank you, Dr. Majid. Thank you, Bob.